Good evening to all. Good evening, doctors. On behalf of JB Chemicals and Pharmaceuticals, I welcome all of you to this important deliberation on the topic fissure in anosurgical and non-surgical approach. To discuss on this topic, we have with us an eminent speaker, Dr. Ashok Ladha, sir. So you can share the screens. Right. So I'll just introduce the eminent speaker. So I'm privileged to have this where I can introduce the speaker. So Dr. Ashok Ladha is an eminent senior colorectal surgeon and past president of ACRSI. Also, Dr. Ashok Ladha is a senior member of American Society of Colon and Rectal Surgeons, also Association of Surgeons of India and Association of Colon and Rectal Surgeons of India. Dr. Ashok Ladha has distinctions to his credit, and those are: first is he has established and published SEPTA as exclusive local anesthesia technique for surgery of benign and anal diseases. Also, he has established national training program in coloproctology under aegis of ACRSI. He has also one more credit where he established fellowship program, the FACRSI, in 1999. Internationally, he established annual colorectal week in Pakistan in the year 2006. And back in India, he established 20th November as the World Piles Day in the year 2007. If I go on, the list will go in multiple slides. So without wasting much time, I would request Dr. Ashok Ladha, sir, to address the group along with his rich clinical experience. On to you, sir.
Thank you, Mr. Shah, for your kind words. I would. Is it okay to go on with the presentation now?
Yes, sir.
Yeah. So, without wasting much time, I would like to take you through the presentation. A very good evening to all the people who have come to hear this webinar on fissure in ano, particularly its management, both surgical and medical. As you would know, I can spend at least a whole day talking on fissure, describing it, starting from the pathophysiology, anatomy of anal canal, and various etiopathogenesis of fissure, which is an information which is accessible to everybody. And I assume, and I'm certain that majority of you know what is fissure in ano as far as the basics are concerned. Today, my emphasis would be on taking you through the most important clinical aspect, the diagnosis, various forms of management, both medical and surgical, and ultimately I'd show you the technique of lateral internal sphincterotomy exclusively under septa block. I hope you'd find it useful, and then we would have ample time to discuss all the questions or queries that you may have. What is anal fissure? Which is a small oval-shaped longitudinal tear in the skin that lines the opening of the anus distal to the dentate line. The skin around anus splits, causing sharp or burning pain with or without bleeding. You know, bleeding from anal fissure is not as excessive as you normally get with the hemorrhoids. And sometimes it is typically described that there is a streak of blood. If the bowel stool is formed, there is a streak of blood on one side of the stool mass, which would suggest to you which side the fissure is in the anal canal. The incidence is difficult to estimate because a large proportion of fissures are self-limiting and are never formally diagnosed, which is a common issue Hence, estimating the frequency of benign anal disease is sometimes very difficult. People tend to live with it. We only treat anorectal diseases which cause distressing symptoms and they require treatment. Nevertheless, it is one of the most common conditions seen in anorectal surgery practice. Anal fissure can occur at any age and has equal gender distribution. Most of the fissure, up to 90%, occur in the posterior midline of the anus, with about 10 to 15% which occur in the anterior midline. So they are mainly dominantly midline pathologies. A small number of patients may actually have both fissures antero-posterior locations. Fissures located elsewhere in the circumference of to the midline should raise suspicion for other diseases and will need to be examined further. They are usually caused by trauma of hard bowel action to the inner lining of the anus. A hard, dry bowel movement is typically responsible, but loose stools and diarrhea can also cause the problem. They are predominantly caused by hard stool. The pain reflexively causes the internal and external sphincters to contract very tight. The external sphincter would relax eventually because it is a voluntary muscle. Unfortunately, the internal sphincter does not relax and remains very tight. It is this hyperactive squeezing that makes the pain relentless and makes it difficult for the split to heal. Increased internal anal sphincter tone is associated with anal fissures, but is likely to play a role in the persistence of a fissure rather than representing the inciting event. Increased tone causes persistence rather than actual causation of the fissure. Fissure is caused by a direct trauma. It is hypothesized that increased sphincter tone decreases blood flow in the area and prevents healing once a fissure has formed. The association between fissures and hypertonic sphincters has been demonstrated manometrically, as has the association between hypertonic sphincter and decreased blood flow to the anodome. Anodome, as you know, is a very sensitive part of the body. Ensuing bowel motions result in more pain, more anal spasm, diminished blood flow to the area, and the cycle is propagated. This cycle of pain and persistence of the anal fissure just keeps on. Treatment strategies are aimed at interrupting the cycle and promoting healing of the anal fissure. Fissures, as you know, could be acute, which is of recent onset, or chronic, which typically have more than 8 to 12 weeks of history. Acute fissures may have the appearance of a simple tear in the anus, whereas chronic fissures may have swelling and scar tissue. The most frequent symptom of fissure, as you would know, is a sharp pain. Patients may describe having a bowel movement like passing a glass or a razor blade. The pain is worst with and immediately after bowel movements. In more chronic cases, and constant pain may be reported as muscular hypertrophy occurs and sphincter spasm begins to contribute to pain process. You must remember that pain which occurs without bowel action in some of the cases may have other etiology, and you must investigate such patients properly with direct interrogation, proper examination, a sigmoidoscopy. Many times, to a practicing coloproctologist, the patient comes and tells that he has the pain, constant pain. Now, this pain is not related to bowel action. There you must make sure that he hasn't got a chronic abscess in the anal canal, a chronic abscess with an internal fistula. That is one. Two, some of them would give you a history of trauma, fall on the bottom, which leads to coccydynia, and which is the cause of a chronic pain not related to bowel action. And these are the cases. Some of them have undergone a sphincterotomy to no avail, and they keep having their pain, so they keep looking for various doctors' consultation. A physical examination patient with an acute anal fissure would likely to have a normal perineum to look at. It may be possible to palpate a hypertonic sphincter with some degree of tenderness. Those with more chronic anal fissure may have a small skin tag, or what we call a sentinel pile, in the posterior anterior position where the fissure is. With gentle spreading of the perianal skin, the most distal aspect of the fissure can sometimes be visualized, rendering additional examination in the acute setting unnecessary. Given the level of pain that patients with this problem experience, it may be difficult to perform digital rectal examination or anoscopy in the clinic. Patients with chronic fissure often have exposed fibers of the internal sphincter at the base and a hypertrophied anal papilla at the proximal end. So that's a typical chronic fissure. It starts with a hypertrophied anal papilla inside, a thick chronic posterior fissure with visible fibers of the internal sphincter and a sentinel pile which hangs out. There may be edema, fibrosis, or heaped up granulation tissue at the edges of the chronic fissure. Quite commonly, fissures are misdiagnosed as hemorrhoid by the patient or the primary care physician due to some similarities in the symptoms. The delay in diagnosis may lead to an acute fissure becoming a chronic one and thus more difficult to treat. Misdiagnosis of an anal fissure may also allow other conditions to go undetected and untreated, like serious infections or even cancer. These less common causes of anal fissure include inflammatory conditions and certain anal infections or tumors, such as Crohn's disease, ulcerative colitis, syphilis, tuberculosis, leukemia, HIV/AIDS, or anal cancer. These diseases cause typical fissures that are located off the midline, are multiple, painless, or non-healing after proper treatment. And these are the ones which should be properly evaluated, or not only by visualization, but proper internal visualization of the anal canal and lower rectum. And hence, a rigid sigmoidoscopy for one is mandatory with the first consultation. When it comes to managing the anal fissure, many patients with acute anal fissure will resolve without any intervention or with a bowel management program, including a hot Sitz Bath, a fiber, psyllium fiber, a high fiber diet, and an increased intake of liquid. Many of them do have disturbed lifestyle, have no time for proper meal, and definitely their liquid intake is much low, which causes hardening of the stool. A Sitz Bath, as you know, is a warm bath in a hot tub of water. The hot water helps to relax the anal muscles. It must be taken after each bowel movement for up to 2 weeks. This excellent treatment of the pain after having a bowel movement helps the patient. The other forms of therapy will need to be used in conjunction with hot Sitz Bath. There is always a question which arises: should any antiseptic be put in the hot bath? It is not required at all. My patients never put any betadine because the idea is to give heat treatment rather than antisepsis. You cannot do antisepsis in the area which is smeared with bowel contents every time. So the idea is to give some heat to the sphincter. Fibers such as complex carbohydrates, which bind with water in colon, creating large, softer stools. Contrary to the logical thinking, a large bowel movement is more advantageous than a smaller or loose bowel movement. Larger, softer stools stretch and relax the sphincter muscles, helping the blood flow. Large, softer stool. Important is to have a softer stool. They may be large. They require less pressure to pass. The less one has to bear down to have a bowel movement, the less spasm occurs and less blood flow. There's less blood engorgement into the hemorrhoids, because quite a few of such patients do have hemorrhoids, and constipation leads to engorgement of these hemorrhoids, further reducing the space through which bowel motion is to pass. Water is very important as it is soaked up by the fiber, making the stool bulky and soft. At least 10 glasses of water intake is necessary per day. Caffeine and liquor are diuretics and cause dehydration. Therefore, coffee, tea, caffeinated sodas, and liqueur should be avoided and should not be counted as water. Water is water, and we need to give them good 3.5 to 4 liters a day. Topical anesthetics such as lidocaine can be used for anal pain along with topical steroid for a very short term. A short course of a combination of ofloxacin or nidazole helps in treating a concomitant intestinal bacterial infection, and a non-narcotic analgesic may be needed to relieve the patient of unrelenting pain. Fecal softeners and lubricants help ease out the bowel movements. These general non-operative measures will help achieve resolution of pain and bleeding and potentially heal greater than half of the acute fissure with virtually no side effects. So we can, in an acute setting, treat at least 50% of these fissures with good medical management. What could be other medical management? And importantly, one group is topical nitrites, which release nitric oxide and result in relaxation of the internal sphincter, which decreases sphincter pressure and subsequently increases blood flow to the injury site, resulting in healing of the fissure. In a meta-analysis, nitroglycerin ointment was found to be marginally superior to placebo in terms of healing, that is about 49 versus 35%. Although some of the studies have shown more successful results. However, adverse effect of topical nitrates include severe headache. The estimated incidence of severe disabling headache is about 70% plus. These can often be resolved by decreasing the amount of ointment used, but in some patients, it requires the pain doesn't go away, so patient himself prematurely stops the treatment. Hence, recurrence rate after resolution with topical nitrites may be as high as 50%. Recurrence rates are higher with nitroglycerin than with surgery if you compare it with surgery. Another little problem as far as compliance is concerned, majority of patients who you see in your OPD on their left lateral side, you'd find that the ointment is all on the outside of the anal canal. Ointment has to be applied where the disease is, that is inside. And sometimes, like, it is difficult to even do a proper rectal examination. Patient finds it extremely difficult to apply the ointment, which must cover the whole thickness and the length of anal canal, which is about 4 centimeter. Now, it is very difficult in some cases, hence the compliance and concomitantly the success rate is low. There are calcium channel blockers, which usually either are nifedipine or diltiazem, can be compounded into topical gel that relaxes the internal sphincter and promotes blood flow. Oral formulation may also be used, but they tend to have systemic side effects, primarily hypotension or orthostasis. Prospective studies have demonstrated healing in about 68% of the patients by 8 weeks of follow-up, and others have shown healing rates of 95% compared to 50% with that of placebo. This is a little high. 95% in practice is very difficult to achieve because of low compliance, but there are some studies published. However, till date, the US FDA has not approved its indication for the usage in chronic anal fissure. So choice between nitrates and calcium channel blockers is somewhat practitioner dependent. As nitrates cause more problem, calcium channel blockers, which are new, are more of a choice. There's an important aspect of fissure in ano, and that is a topical use of metronidazole application. After a landmark paper a few years ago, it was found that chronic anal fissure may have a wide spectrum of pathogenic organisms in the base, particularly anaerobic bacteria being present in half of the cases. Patients with anaerobic bacteria grown in culture, when treated with topical metronidazole, experience a rapid relief in pain and anal sphincter spasm, along with enhanced fissure healing rate of 95%. Now, we are talking of those 95% of chronic fissures who have not yielded to any treatment and have shown to grow the anaerobic bacteria, which may be gram positive or gram negative. Out of those half cases, 50%, the relief rate and the healing is as high as 95%. So if we really have 10 cases of acute anal fissure, or some of them going into chronic segment, about half of them can be managed very effectively with medical management of high fiber diet, Sitz Bath, and an oral antibiotic for 5 days. Rest of them, if they don't get better with medical management, are then resorted to topical application of nitrites or calcium channel blockers, along with lidocaine and topical metronidazole. It sometimes can be very difficult to practice a swab from the floor of chronic anal fissure and try and grow a gram-negative bacteria. So the plan of treatment would be to apply a lidocaine along with a topical metronidazole gel, which can give relief in more than 50% cases. So it is worth trying. Then come more invasive treatment like chemodenervation using botulinum toxin. Botulinum toxin, as you would know, is produced by bacterium Clostridium botulinum and acts on the presynaptic nerve at the neuromuscular junction to prevent release of acetylcholine. This temporarily paralyzes the internal sphincter. There is a significant variation in the amount of toxin used, but typically 40 to 100 units is normally injected in the internal anal sphincter to relax it for good 2 to 3 weeks, so that some healing of the fissure can occur. It is well tolerated by patients and may work best in conjunction with the topical nitrate or calcium channel blocker. However, recurrence rate may be about 42%. So far, all the therapies that we are talking about get you a healing in about 50 to 60% patients. However, it comes with a cost. So cost effectiveness, high rate of recurrence, a well-performed sphincterotomy with or without excision of chronic anal fissure scores over the use of botulinum toxin, even in Indian scenario. So we come to the surgical management, mainly for chronic anal fissures or those patients whose acute anal fissure is also really disturbing their normal routine of life, including the work. They may sometimes require what we call a lateral sphincterotomy, which has a very high healing rates of up to 95%, low recurrence, which make this as the gold standard of treatment for anal fissures. A Cochrane analysis of randomized controlled trials found it to be very effective, up to 95% when comparing non-healing at the median of 2 months of surgical treatment versus medical treatment. So it's very high treatment rate, very high cure rate, and a low recurrence. It can be performed as an open or a closed procedure with equal results with regard to healing, recurrence, and complications. This surgery can very successfully and comfortably be undertaken under a local anesthetic septa block. The overall incidence of disturbed incontinence after lateral internal sphincterotomy was reported to be 14% in a systemic review, which included more than 4,500 patients, with majority reporting problems with flatus, silage, and seepage rather than accidental defecation, which occurred in less than 1%. In addition, most of the incontinence of the lateral internal sphincterotomy, we all know, is very transient, and it doesn't really disturb the routine life of the patient. To address the issue of incontinence, the idea of a tailored sphincterotomy with division of the internal anal sphincter to the length of the fissure rather than to the dentate line has been described. Only divide as much sphincter on the lateral side, which covers the length of the fissure. Patients with other risk factors for fecal incontinence, such as those with previous sphincter injuries or an attenuated sphincter after childbearing, should be offered LIS with more caution than others. Fissurectomy, which is excision of anal fissure in conjunction with LIS, is found to have low complication rate, 95% resolution, and improvement at the end of 12 weeks. When patients do not have a hypertonic sphincter, they may be less likely to respond to treatments aimed at typical fissures. These patients may be, they are not too high though, but there are some patients who have a normal anal tone but have a non-healing fissure. So these patients may be particularly well suited for consideration of fissurectomy. You excise it with dermal advancement flap or a mucosal advancement flap. You cover the raw area. In case with hypertonic sphincter, prospective studies have suggested a modified left internal sphincterotomy to the level of the fissure apex with a dermal advancement flap, which appears to result in a better healing and less postoperative pain. This can be done like a V-bioplasty. When a fissure is off the midline, an additional diagnosis such as Crohn's disease, tuberculosis, HIV, or a sexually transmitted infection should be considered. In general, patients with Crohn's disease should not be treated with a sphincterotomy. In Crohn's-related fissures that appear more typical and are associated with sphincter hypertonicity, medical management similar to the approach of a typical fissure is reasonable. However, Crohn's-directed medical therapy is essential and mandatory for these patients when their fissures are a manifestation of inflammatory bowel disease and are not just standalone diseases. When sexually transmitted diseases or other infection is suspected, cultures and biopsies are required to identify the organism. HIV-related ulcerations are addressed by optimizing retroviral therapy. Other infections such as syphilis, herpes, and gonorrhea can all produce fissures. These should be appropriately managed and patients should be counseled regarding transmission of the infection. I would now like to take you, we have done about 32 minutes, would now like to take you with my video on surgery for fissure in ano under pudendal, that is septa block. Patient septa block can only be given in lithotomy position. As you can see, we start from 6 o'clock, go circumanally. We use a 2% lignocaine with adrenaline. Then we go on the right side first into the right iliac fossa, then the left side, and then in the pre-sacral area, inject about 3 to 4 ml, and then anteriorly, just to give a complete circumanal pudendal block. This is septa, which is simplified and easily reproducible for all kinds of surgery. After the septa block is given, patient has got some little sedation given in the form of IV midazolam, titrated, diluted with water. Then you take the left index finger and lubricate. You have to be very extremely gentle when you're doing any anal surgery under local anesthesia. You insert the finger, hook the finger, and pull the whole sphincter mechanism down like I'm doing. This relaxes the sphincter completely. The sphincter is relaxed. Then you can put the anal speculum. Again, gentleness is the key. You have to be extremely gentle when you wish to do any surgery in the anal canal, because one fissure, and otherwise too, as you would see, a chronic anal fissure would come into view, a chronic posterior anal fissure you would be able to see. And even the fibers of the fissure posteriorly are exposed. I always excise the chronic anal fissure. As you can see, the fibers are all exposed here. I'm just excising using a knife. We excise the fissure completely, and there is, as you can see, there's a hypertrophied anal papilla at the inner end. We just get hold of the fissure, and with a sharp dissection, it doesn't lead to any bleeding. You can see the anal sphincter is very nicely dissected out. This is the anal sphincter posteriorly. Very nicely dissected out. You can see the fibers of the anal sphincter. Is that visible? These are the fibers of the anal sphincter. And with the sharp dissection, I do not normally use any diathermy at all for these kind of surgeries. We excise along with, this is the hypertrophied anal papilla. This is excised completely along, and you can see the posterior part of the anal sphincter is nicely visible. If you keep it compressed for a little while, you would find that the bleeding stops. You do trim all the edges properly. You should try and make a clean wound. This is a clean wound which would heal normally. If you look at this, say after about 6 to 8 weeks, you can see it is completely excised. You would hardly find any scar here. Oops, sorry. Sorry for this, just the wrong button got pressed. I would not ever do any posterior sphincterotomy. However, it may look very tempting that you do a sphincterotomy from the base of the fissure, which you should try and avoid. I would show you how to do a lateral sphincterotomy. You can call it closed or open. I just don't know. But it's a simple way of doing a sphincterotomy. That is the edge where you can feel the internal sphincter and the groove between internal and external sphincter just there. So we make a little nick there. We feel the edge. That is where the edge is. We just make a sharp cut, a small tiny cut there. We take the scissors and raise the skin and the mucosa, just like that. Be very gentle. Just release the skin and the mucosa from the sphincter. With gentleness, you would avoid making any hole into the mucosa or the skin. So this is raised up to this is the dentate line, and that is the edge of sphincter. As you can see, I am going in the intersphincteric area. I'll just open the scissors. That is the sphincter. As you can see, there is no need to deliver out the sphincter. You can just cut, and as you can see, there's hardly any bleeding. There's no bleeding. All you require is just a pair of sharp, fine scissors and do a sphincterotomy. Just feel the groove and the job is done. I normally put a small dressing soaked in U-Sol and smeared with local anesthetic gel. Patient goes into the ward. There is no drip given. Takes oral medication in the form of ofloxacin or nidazole, painkiller, and a lubricant in the form of cremafin or something like this. He would straightway start feeding himself, and the job is done. They normally go home the same evening or maybe next morning with a soft diet, plenty of fluids to drink, hot Sitz Bath, and if at all required, a bit of local anesthetic gel application. Otherwise, soft normal stool up and about. There is no need of any injectables at all. That finishes my talk. I hope you found it useful. If there are any questions, do kindly let me know. I'd be happy to reply.
Yeah, good evening to all of you. And first of all, I would like to thank Dr. Ashok Ladha for giving such a wonderful talk on fissure in anosurgical and non-surgical approach. And I think the session was really very informative, sir. And I believe that today each and every one of us have learned something new and would inculcate them in our practice. Now I request all our viewers to put up their questions in the chat box, which you can see it in front of your screen. We'll take up the questions one by one. Sir, I've received already some of the queries, interesting questions, set of questions.
Sure.
First question is from Dr. Mahesh Kriplani. He's asking is what is the best technique? What is the best thing that can be done at the first step while doing the abscess drainage?
Oh, I thought we were going to be talking on fissure. This is a little irrelevant, but anyway, I'll answer that. If you have a perianal abscess, you must first do investigations in the form of a transperineal sonography to see where exactly the abscess is extending to, and then you have to drain it. So the only thing I can suggest at this juncture is to drain it as near to the anal margin as possible, because majority of these abscesses, once drained, do ultimately culminate into a fistula in ano, and away you drain, the fistula is going to be long. So to help the patient, drain it as near to the anal verge as you can. Drain it out completely. If you are experienced enough, or if you can see the internal communication, open the fistula, your chances of recurrence would be much, much less.
Next question is being asked by Mr. Vijay Kumar Apte. What is the role of Botox in anal fissure, sir?
Well, as I explained, one, it is an expensive material. Two, as I told, the recurrence rate is still in excess of 40%. So Botox relaxes the internal sphincter for some time, and the objective is to somehow relax the anal sphincter for good 4 to 6 weeks if you can, to enable the fissure to heal. However, the recurrence world over has been shown to be about 40%. So if you can rather master the technique of lateral sphincterotomy, your patients would be much better off.
There's another question from Hitender Suri. There are a lot of cooling devices like GMS piles, reliefs, chirocare, and hemorrhoid available. Are the devices effective in fissure? Can they heal fissure, or they just provide temporary relief?
No. I think that would not heal the fissure. The so-called cooling, is he talking of cooling devices? What devices?
Yeah, cooling devices.
Yeah, but cooling, they are sort of over-the-counter devices. And I think they are extremely difficult, one, to put in. Two, the excruciating discomfort and pain that it would cause you would be unbearable. So and particularly anal fissure, you cannot relax the sphincter. So I think they should be avoided.
Another question by Rajendra Sonekar. In some of his patients, he observed that after doing a lateral sphincterectomy, symptoms of fissures have not relieved. What could be the probable cause, sir?
Perhaps your diagnosis was incorrect. Maybe patient does have something more. Any surgery that you perform, you must always investigate, work up the patient properly. You must know that he doesn't have anything more than a fissure. So that is one. Your diagnosis should be proper. Two, your sphincterotomy should be proper. If you have done the sphincterotomy improperly and you find that the post-operative anal sphincter is still quite tight, that means your sphincterotomy is incomplete. Three, as I said, in a chronic fissure, try to excise the fissure. I don't know why people do not excise the fissure. It doesn't cause any comorbidity at all, but it does get rid of the pathology. If the fissure is large and if there is a inflamed edges, you must excise it. These are the 3 points that I can suggest. And if you find that the sphincteric tone is still high, do consider doing a proper sphincterotomy.
There's another question, sir, from Dr. Prasanna Patnaik. What is the plan of treatment in posterior fissure fistula complex?
Posterior fissure fistula, you would find that they are invariably small. They start from the base of the fissure and just come out. And you'd find that the central pile is in between X like a bridge. These must be excised. You can excise in toto both the fissure, the central pile, and the fistula, which is not very large. You excise it completely, and if at all there is a tight sphincter, do a sphincterotomy on the lateral side. But you must excise the whole complex, and they do quite well.
Sir, any role of laser therapy in managing fissures?
Yes, people do that, but where would you put the laser? People use laser for cutting the sphincter, which I did with a small scissors. So just bringing the thing out and then having a laser, which I'm sure costs money, and just cut it with a fiber, I don't really find it useful. Why can't you cut it with the scissors? Otherwise, you cannot put a fissure to put a laser to burn the fissure. I think you would create more havoc. So I personally feel if you have one, and if you want to use it, then use it for cutting. Otherwise, I don't find any indication of laser in treating a fissure.
So the next question is from Dr. Ashish Ganatra.
Yes.
Does plain metronidazole helps healing, or we need to add lignocaine or any other vasodilators locally?
Well, plain metronidazole would not be effective. See, Fisher has a plethora of symptoms. It is chronic because it remains infected. It has got tight anal sphincter, which has to be relaxed. And then there is pain during defecation. So I think what I normally do is I suggest the patient to apply local lignocaine before passing the motion. You put I show them how to do that, and I would much prefer a gel rather than an ointment, because gel can be put in properly. You apply the gel at least 5 minutes before going to the loo, and you pass the motion, sit in the hot water, and then subsequently apply a combination of metronidazole and a nitrite of some kind, or a calcium channel blocker.
There's another question from Dr. Rajiv. Is in your opinion, which is the better option? It's whether it's open or closed lateral internal sphincterectomy.
Well, in my opinion, the best is what I showed, what I did. And I find it very quick, very effective, and doesn't cause much of a bleeding. Hasn't given me any problem like an abscess or anything. So I personally would not like to deliver, like a lot of people do, deliver the sphincter out through the small opening by hooking it onto an artery forceps. I think that is not required. I think you can very certainly do what I did without bringing it out. So it all depends on your experience, what you wish to do. I think they are all good, provided you should know how to do it.
So the best local anesthesia to perform the lateral sphincterectomy?
Well, the best local is the one which have stood the test of time. Best perhaps is the simplest. Just use, like I do, a 2% xylocaine in a prepared solution with 1 in 200,000 adrenaline. I use between 18 to 20 ml of the fluid, and not only for anal fissure, I do it for septa. And as you would all know, the world knows that I do every surgery for benign anal condition, may it be fissure, fistula, hemorrhoids, or rectal polyps, under septa block only. So a 2% lignocaine. I do not put any bupivacaine or sensorcaine into it. 2% lignocaine with 1 in 200,000 adrenaline. I find it to be quite useful for surgeries lasting about 90 minutes.
There's a multiple questions are being asked by Dr. Yogendra Rai. His first question is with respect to septa block. How much deep in terms of centimeters should anesthesia be injected in each ischiorectal fossa to block a pudendal nerve?
Like, you have to go into ischiorectal fossa. I have shown this technique many times. You have to go for about 3.5 inches, 3 to 3.5 inches to get into the ischiorectal fossa, and about same length, maybe 3 inches in the pre-sacral area. Anteriorly, you should not go that deep. So the idea is to pour the fluid into the ischiorectal fossa, and you can reach ischiorectal fossa at the depth of about 3 inches on either side.
The spinal needle number used in septa block?
You can use anything. Once you have done a perianal blockage, you can use any needle. Patient doesn't feel anything. I normally use a 20 needle, which doesn't give too much of resistance to my thumb when I push it.
The same doctor is asking another question is like, perform during septa block while injecting at 12 o'clock position, how much deep it should be injected,
well, as
so
I said,
that you should not hit the prostate gland?
Right. So you should know how deep the prostate gland is. You normally go for about 2 centimeter, 2 to 2.5 centimeter, not more than that.
And so during septa block, after injecting in both ischiorectal fossa, what is the role of head-low position during anesthesia?
It is not required. Normally, any surgery that you do a head low when you're doing it in lithotomy. And as you know, septa can only be given in lithotomy, because in lithotomy position only, the pudendal canal comes at the most dependent part for the fluid to drop straight onto it. So a little head down is otherwise required for a good lithotomy surgical position.
There's another question is with respect to the recurrence rate. So, what is the recurrence rate of fissure? Is it more if the LIS is done under the local anesthesia as compared to general anesthesia? Is it true?
Well, I think this is a very irrelevant question. The idea is to give, idea is the lateral sphincterotomy. The anesthesia is immaterial. If you know the job, if you do it properly, then it doesn't matter whether it is done under local or a general anesthesia.
Dr. Sagar is asking a question is with respect to the causes of infected LIS wound. It has happened in 2 to 5% of his patient and no anal mucosa is perforated while doing the procedure. So what could be the reason, sir?
Well, as I say, majority of problem in the anal area occur because of a faulty technique. You must know the technique properly. If you have really traumatized the mucosa while doing a lateral sphincterotomy, there are a couple of things that you can do. If that is the case, then you leave it open. Don't try to suture the rent that you have created, because that would invariably get infected. So I would then go in and open the whole area and leave the sphincterotomy open there. There's no need to repair it. It would heal with a second intention, because the infection only occurs if, one, there is collection of blood, and two, there is an excess of fecal matter going to that collection. That is when the infection would occur. So if at all you inadvertently cut the mucosa, just open it and leave it open. It would heal nicely.
Another question is with respect to, sir, medical management. What is the role of calcium channel blockers and steroidal local application, and when it is recommended while managing fissure cases?
Lots of preparations do have hydrocortisone into them. I would suggest that if at all you have to use it, one, don't use it when there is a visible infection in the form of induration or abscess. Don't use steroid. Two, if you are going to be using steroid mainly in acute setup, then use it for a limited period of time. The problem is that the patient keeps on applying it, and we see patients who have applied steroids for a year and the whole skin becomes very thin. So steroid, if at all, they have a role only for a limited period of time to tide over the initial pain and inflammation cascade. But don't keep on applying it. It doesn't relax the sphincter. It doesn't make the sphincter, make the fissure heal.
Yeah, I think, sir, I think most of the questions have been answered. I think, sir, many of the questions are actually repetitive. So I think, sir, any closing, concluding remarks that you would like to give, sir?
The only thing I would say is a common problem. Every patient who comes and sits in front of you in your consulting says he has got piles. Don't take patient's word for it. Try and ask some direct questions about pain, the quantity of bleeding, the frequency of bowel stools. A patient who has a frequency of bowel stools more than 5 to 6 times with passage of mucus, then be aware he may be harboring a disease, a mucosal disease, so you have to do a proper workup. That is one. Examination, a coloproctologist, those who are aspiring to be coloproctologists must make sure, like I always teach, I've been teaching it for last 40 years in India, you must always do a rigid sigmoidoscopy. It takes a little effort, but it does give you a lot of information. I always do sigmoidoscopy even in my fissure cases, only perhaps in a 1% case who are very painful. Otherwise, I am able to do a sigmoidoscopy if I know the technique properly. You must always visualize the inside of anal canal and also the rectum to make a proper diagnosis. Tell the patient what exactly is wrong with him. Don't just suggest surgery. Once you are well established, then people would come only for surgery to you. But otherwise, do try some medical treatment. If it has not been tried properly before really jumping onto surgery, you would be able to gain the confidence of the patient. Surgery is something which should always be asked for, should not be offered, particularly in benign diseases. Then you would find your rate of success is much higher and the patient confides in you. I think these are the concluding remarks that I would like to give you.
Yeah. So once again, sir, thank you so much, sir, for your wonderful session. And I would also like to take this opportunity to thank our viewers for their participation and deliberation. And with this, I would like to invite our sales head, Mr. Pranav Shah, to conclude the event with a few words.
Thank you.
Thank you, sir.
Thank you, sir. I think on behalf of the entire group, I would like you to thank you for enriching them with your rich clinical experience. So on behalf of the entire group, we would like to thank you for your valuable support that you have given to us. And the entire enlightening session where I believe, a lot of queries of lot of doctors would have been answered by now. And I would like to thank the entire audience for sparing their valuable time during this COVID. And we, on behalf of JB Chemicals, who are basically manufacturers of Metrogel, where we have also introduced products like Ano Metrogel M. These are the combinations that we have. So we would wish all of you and your family a very, very safe time at home. Thank you so much, sir.
Thank you, Mr. Shah. Enjoyed it. Thanks a lot.
Thank you so much. Thanks.
Bye-bye. Bye.
Bye.
Bye.